Hello all, welcome back. Today we'll be discussing GIT for surgery. This was the topic breakdown given in the blueprint. So GIT, corrosive esophageal injuries following foreign body, esophageal cancer, upper GI bleeding, peptic ulcer, surgical management of obesity, lower GI bleeding, then appendicitis, bowel obstruction, IBD, colon cancer screening, colonic polyp, colon cancer as proper, and diverticular disease, PR bleeding, rectal conditions, and biological signs. Today, I'll be mainly discussing esophagus and stomach. So let's get started. So I've just added a slide so that you remember the blood supply of the GIT. So from the abdominal aorta, we have celiac trunk, we have superior mesenteric artery and inferior mesenteric artery. These are the main three arteries which are supplying the GIT. From the celiac trunk, we have three branches: left gastric artery, common hepatic artery, splenic artery. I'll show the picture and tell that in detail. That is the artery of the foregut. Then superior mesentery has five branches. It is inferior pancreatico-duodenal. So superior pancreatico-duodenal is coming from the branches of celiac trunk. Inferior pancreatico-duodenal is coming from the superior mesentery. Then we have intestinal arteries, ileocolic artery, right colic artery, and middle colic artery. Okay. Inferior mesentery is supplying the hindgut, which is dividing into left colic artery, sigmoid arteries, and superior rectal arteries. Okay, so mainly up to the second part of duodenum is supplied by the branches of celiac artery. From there, inferior pancreatico-duodenal, intestinal, ileocolic, right colic, and middle colic. Right colic and middle colic up to the transverse colon is supplied by the superior mesenteric artery. The left colic and sigmoidal. So there is left colic for the descending colon, sigmoidal for the sigmoid, and superior rectal for the upper rectum. Those part is supplied by the inferior mesentery. Okay. Then after abdominal aorta is also giving renal branches, right and left, and gonadal arteries. Okay. Now we'll come to the supply of stomach. This is important because we have to know um, when there is a bleeding, we have to know which artery to ligate or focus on during angioembolization. So as mentioned, celiac is having a branch which is called left gastric. It is having another branch which is called splenic, and it is having another branch which is called common hepatic. So three branches from celiac trunk. So that is left gastric and splenic, as well as common hepatic. Now this so there is stomach is having one lesser curvature and greater curvature, right? So lesser curvature is supplied by the gastric artery. Gastric artery is supplying the lesser curvature, wherein the left gastric is the direct branch of celiac trunk, and the right gastric is a branch of common hepatic. Okay, right gastric is a branch of common hepatic. So common hepatic is giving out a branch which is called right gastric, which is supplying the lesser curvature. Now the splenic, as it is going the splenic can give out the short gastric branches, as well as this greater curvature is the artery is called gastroepiploic, okay, or gastromental. So that is left and right gastroepiploic. Right gastroepiploic is coming from the gastroduodenal artery. Okay, so there is a gastroduodenal artery which is a branch of common hepatic again. So common hepatic gives out uh, gastroduodenal. So gastroduodenal is coming down and it is giving out a right gastroepiploic artery, and the rest of the part is called superior pancreatico-duodenal. Okay, superior pancreatico-duodenal. This gastroduodenal artery is important because this is the artery that is bleeding while there is a perforation on the posterior aspect of duodenal in case of duodenal ulcer. So posterior ulceration and perforation of duodenal ulcer, the bleeding is from the gastroduodenal artery. This is an important point. Okay, so the greater curvature supplied by the left gastroepiploic, right gastroepiploic coming from the common the gastroduodenal artery, and left gastroepiploic from the splenic artery. Splenic artery also gives a pancreatic branch, and it can give short gastric branches are coming from all of these. And now we have the common hepatic, which is already given the right gastric artery. It is given the gastroduodenal artery. After it gives these two branches, it's called the proper hepatic artery. Now this proper hepatic artery divides into right and left hepatic artery. Right hepatic artery and left hepatic artery. The right hepatic artery gives another branch, which is cystic artery. So in short, the foregut is supplied by the celiac trunk. Celiac trunk has three main branches, which is left gastric, splenic, common hepatic. Left gastric is supplying the lesser curvature. Also there is a right gastric which is coming from the common hepatic. Okay, splenic is going supplying the spleen. It gives off a pancreatic branch. It gives off a left gastroepiploic branch which is supplying the greater curvature of the stomach. Then common hepatic, it is given off right gastric already. Then it gives gastroduodenal artery. Okay, gastroduodenal artery has given off one right gastroepiploic artery which is supplying the greater curvature, and it gives off also superior pancreatico-duodenal artery. So gastroduodenal artery is the artery which is bleeding in case of the duodenal ulcer which is perforated. Then we have common hepatic, which is given off these branches. It is then called the proper hepatic, which divides into right and left hepatic. Right hepatic gives off a cystic branch for the gallbladder. Okay, so this is the arterial supply of the stomach. Now hepatic circulation. There has been one question which asked which artery or which vessel supplies or gives the most important blood supply to the liver. So it is from portal vein. Hepatic portal vein is the most important vessel of liver. 70% comes from hepatic portal vein, which carries blood filled with absorbed nutrients from the digestive organs to liver, where there is detoxification. Then it gives off to the IVC before it reaches the heart. So oxygen-rich blood enters from the hepatic artery. So hepatic artery also supplies liver, that is carrying oxygen-rich blood to the liver and mixes with the blood from the hepatic portal vein in the sinusoids. Blood exits the liver via the hepatic vein into the vena cava. So hepatic portal vein carries 70% blood to the liver. Also hepatic artery carries blood to the liver. Hepatic vein takes it to the IVC and then it drains to the heart. Okay, now we'll come to certain diseases. One is GERD. GERD means gastroesophageal reflux disease. So what is gastroesophageal reflux disease? So we have esophagus, okay, which is our food pipe, and it has an upper esophageal sphincter and a lower esophageal sphincter. Now this lower esophageal sphincter is preventing the reflux from the stomach to the esophagus. Now why is that important? Because stomach is having acidic nature, and if that acid is chronically getting refluxed into the esophagus, there can be esophagitis, okay, there can be ulceration, there can be GERD, there can be metaplasia of the esophageal lining, wherein the normal squamous epithelium may get replaced by the columnar epithelium due to the stress from the acidic reflux. So these all can happen. That is why we are having a lower esophageal sphincter. But when the lower esophageal sphincter is abnormal, or there is some problem with the lower esophageal sphincter, the acid gets refluxed into the esophagus and can lead to chronic esophagitis, GERD, and it can predispose to Barrett's esophagus, which can be a great risk factor for esophageal adenocarcinoma, because the normal squamous get replaced by the columnar epithelium. Okay. Now, what happens in GERD? So GERD, if in one word, if you have to say what happens in GERD, it is transient lower esophageal sphincter relaxations. Okay, transient lower esophageal sphincter relaxation. So reflects exclusively by this sphincter relaxation. In that case, it is confined to the distal esophagus. Okay. Then what happens when there is an impairment of the gastroesophageal junction? Uh, okay, when there is a sliding hiatal hernia and all, there can be this reflux, and it can lead to reflux symptoms. The typical symptoms of reflux are heartburn, regurgitation, acid brush. Atypical symptoms are chronic cough, wheezing, dyspnea or shortness of breath, voice changes, sore throat, globus sensation or a mass-like sensation in the throat. These are the alarming symptoms, which means there is something wrong beyond the GERD. It may have progressed to Barrett or even adenocarcinoma. So these are alarm symptoms, which are dysphagia, odynophagia, anorexia, satiety, weight loss, and GI bleeding. Okay, so this GERD can predispose to esophagitis, erosive esophagitis, and Barrett, and finally adenocarcinoma. So what are the tests we usually do for this GERD before an anti-reflux surgery? We'll talk about the surgery later. So we do pH testing, which is considered the gold standard test for this GERD, acid reflux. So that documents a pathological acid reflux. Then we can do a barium esophagogram before the surgery, just to identify if there are any structural problems. Manometry is done to rule out achalasia. Okay, and esophagoduodenoscopy, OGD for evaluating the mucosa for esophagitis, strictures, ulcerations, Barrett. Maybe you can do a biopsy to get a histopathological diagnosis and other anatomic abnormalities. Now this is how we do a manometry, and this is called Chicago classification for manometry, because when we do a manometry, we can identify if there is actual achalasia like thing or other uh, contractile problem or spasm with the esophagus. So this is called the Chicago classification. Now, GERD, what was the problem? There is acid reflux because the lower esophageal sphincter relaxations. Okay, in achalasia, there is failure of relaxation of the lower esophageal sphincter. Again, those are all problems with the lower esophageal sphincter, and it leads to building up of pressure in the esophagus. There may be difficulty in swallowing. Okay, so how do you diagnose this? So you perform manometry by making the patient to do bed swallows, 10 bed swallows in a primary position. Primary position means the patient is supine. They are asked to do a 10 bed swallow, usually 5 ml, 30 seconds apart. Then if there is abnormal median IRP, IRP means integrated relaxation pressure. If there is any abnormality in the pressure, that means if there is 100% absent peristalsis, that is all of the swallows are either failed or premature, then it is achalasia. Achalasia can again be 1, 2, 3. That is depending on the panesophageal pressurization. That means the pressure builds up in the esophagus. There is no active peristalsis. That is according to that you classify this. If there is no panesophageal pressurization but there is 100% failed peristalsis, it is achalasia 1. If more than 20% swallows has panesophageal pressurization, it's 2. And if more than 20 swallows with premature contraction and failed peristalsis, it is 3. Okay, just remember that if there is abnormality in the manometry with panesophageal pressurization or failed peristalsis, it is called achalasia. Okay, if there is no abnormality in the peristalsis but the it is due to some other obstructive thing, it is esophago-gastric junction outlet obstruction. Okay, now if we don't find any abnormality in the median pressure while doing the wet swallows, we can make them do the swallows in sitting position. Okay, or we can do them make them do MRS RDC. What that mean? Multiple rapid swallows. That is like 2 ml rapidly, and or a rapid drink challenge like 200 ml as such as a big gulp. If there is abnormality, that may be achalasia, or if there is no abnormality in the pressure, no panesophageal pressurization, but there is 100% failed peristalsis, it may be due to absent contractility, or more than 20% swallows with premature contraction, it may be distal esophageal spasm, or more than 20% swallows with hypercontractility, it may be hypercontractile esophagus, or more than 70% ineffective or more than 50% failed swallows may be ineffective esophageal motility, or it may not bring out any evident pathology also. So in short, manometry findings are classified based on Chicago classification. If there is abnormality in the pressure with the building up of pressure in the esophagus with absent peristalsis, may be achalasia, or it may be other contractile problems like absent contractility, hypercontractility, esophageal spasm, etc. We'll come to the Los Angeles classification of esophagitis. So esophagitis is classified A, B, C, D. Why we understand this is because C and D are more severe than A and B. If the mucosal break is less than 5 mm, that does not extend between the top of two mucosal folds, then it is A. If it is more than 5 mm, okay, uh, and it does not extend between the tops of two mucosal folds, it's B. It's more than 5 mm. This is less than 5 mm. Now C means there is a mucosal break that is continuous between the tops of two or more mucosal folds that involve less than 75% of the circumference, and D means there is at least 75% of the circumference mucosal break is there. That is called D. Okay, so these are different things like we told. What is GERD? NERD means esophageal reflux, non-erosive reflux disease. Then we can have achalasia, or we'll just see the difference. I don't want you to know the whole table, just see the difference. So Los Angeles C and D esophagitis in the endoscopy, that is all diagnostic of GRD. Okay, not A and B, C and D only. or peptic strictures or Barrett esophagus. They all can be seen in GRD with the reflex acid reflex. Okay, in Achalasia, what happens is there is in manometry there is building up of pressure. So this is the surgery for uh, this gastroesophageal reflex disease. It's called Nissen fundoplication. Uh, it is a 360-degree stomach wrap around the esophagus to prevent the reflex. But what you have to remember is this surgery cannot replace medical management, because this surgery cannot prevent the risk or decrease the risk of development of Barrett, or it cannot prevent the risk of adenocarcinoma. It can only give a symptomatic improvement to the patient. It can relieve their distressing symptoms, but it cannot replace the medical management. So you have to give them a proton pump inhibitor. Okay, if needed, you can. This is an acid reflex surgery, like we told, anti-reflex surgery. This is a Nissen fundoplication. Nissen fundoplication is a full wrap or a 360-degree wrap where the stomach is wrapped around the esophagus and stitched in the front. Okay, buttress, buttress sutures. There are other wrap also, which is called the partial wrap, where there is door fundoplication, which the stitch is in the posterior aspect, or toupee in the anterior aspect. Stomach wraps around the back of esophagus. In door, stomach wraps around the front of esophagus. Okay, there are partial fundoplication and Nissen fundoplication. The preferred one is Nissen fundoplication. If it cannot be done due to some problem, we go for partial. Now coming to Barrett's, which is one of the complication of gastroesophageal reflex. So what happens is usually the esophagus has a squamous epithelium. Okay, it has a squamous epithelium like like that, flat epithelium. But due to prolonged acid exposure, what happens is it becomes columnar epithelial cells. Okay, and also it is intestinal metaplasia. That's what it is called. So intestine has goblet cells also. Goblet cell. Okay, goblet cells are like vacuolated cells. Okay, which is producing mucin. Here you can see the goblet cells. So this is metaplasia. Metaplasia means normal epithelium is replaced by the abnormal epithelium. So Barrett is defined as a metaplastic change of the epithelial lining of distal esophagus from normal stratified squamous to intestinal columnar, containing also goblet cells. So we need endoscopically to identify the abnormality in the mucosa along with the histopathology to give evidence of goblet cell, then we can call it Barrett's esophagus. Now, how do you document Barrett's esophagus? It is by Prague classification. Prague classification means you are identifying the extent of Barrett by M and C score. M means it is the maximal extent, that is at the top of the Barrett esophagus tongue from the gastroesophageal gastroesophageal junction. That is called the maximal extent. What is the circumferential extent? It is from the squamocolumnar junction, that is the lower bottom of the this Barrett tongue, to the gastroesophageal junction, that is called the circumferential extent. That is Prague classification. Now when you have a Barrett, you have to know whether there is dysplasia or atypia in the cell. Okay, Barrett just means metaplasia. Metaplasia means normal squamous is replaced by the intestinal columnar epithelium. Metaplasia means there is abnormality in the cellular structure, maybe the chromatin, maybe the nuclear structure and all. That may predispose to adenocarcinoma. So to identify that, you go for biopsy, which is by the Seattle protocol. Seattle protocol means that you take biopsy, okay, in each quadrant every 2 centimeter, starting 1 centimeter above the gastroesophageal junction. So pre-classification is also given in this picture. So M means from the top of the Barrett tongue to the gastroesophageal junction, that is the maximal extent. Circumferential extent is the squamocolumnar junction to the gastroesophageal junction. 1 centimeter from the gastroesophageal junction, every 2 centimeter, you take 4 quadrant biopsy. That is called Seattle protocol. So what is the management of Barrett's with no dysplasia? You treat the underlying GERD. You give proton pump inhibitors. Okay, you can give make the patient undergo an anti-reflex surgery, but it does not prevent the progression to adenocarcinoma. You have to know that. Or you may do a mucosal ablation if it's more than 8 centimeters, if it's a large thing, and surveillance endoscopy yearly. If it is low-grade dysplasia, you have to perform biopsy if not done by Seattle protocol. You have to always give PPI and Nissen's fundoplication, which is 360-degree stomach wrap around the esophagus. Endoscopy can be done in 6 months and look for any changes, like if the low-grade dysplasia has progressed to high-grade or to endocarcinoma, endometrial adenocarcinoma. Ablation if it has not responded to PPI or anti-reflex surgery. Then Barrett with high-grade dysplasia, you can do an endoscopy, which is a chromoendoscopy with normal light as well as the it is called a chromoendoscopy. Then you can do an endoscopic mucosal resection. That is for the biopsy and all. You do a tip from the the dysplastic thing and you identify under microscope. And you can do a mucosal ablation. Mucosal ablation, you do it like every 8 weeks or so. You have to do as long as the Barrett the dysplastic changes are there. You have to remove it all. That is called mucosal ablation. And surveillance endoscopy, which can be done every 3 months for the first year, every 6 months for the second year, and then annually. However, whatever you do, nothing can replace the medical management like GERD with medical therapy or anti-reflex surgery. Long-term control of underlying GERD with PPI is must for anything. Low-grade dysplasia, no dysplasia, high dysplasia, whatever, you have to give PPI. For symptomatic management only, you go for anti-reflex surgery that cannot reduce the progression to endometrial adenocarcinoma. If there is low-grade dysplasia, you can do an ablation if it is not responded to PPI or ARS. If it is high-grade dysplasia, again you can go for mucosal ablation and a surveillance endoscopy. Now, what are the indications for surgery in Barrett's with high-grade dysplasia? High-risk features like length more than 2 to 3 centimeter, if there are lymphovascular invasion, multifocality, poorly differentiated lesion, or patient prefer surgery or inability to attend repeat surveillance or procedural endoscopy, inability to eradicate areas of high-grade dysplasia with endoscopic therapy like ablation, evidence of progression despite endoscopic ablation, technically insufficient endoscopic ablation or end-stage esophageal function secondary to motility disorder like stricture or hernia. So this is in short a flow chart which is showing what you do in a GERD. So chronic GERD symptoms more than 5 years or more than 2 risk factors for esophageal adenocarcinoma, which includes age more than 50, male, gender, white race, elevated BMI and smoking. Then you do a screening endoscopy. If there is Barrett or confirmed with the endoscopy and biopsy, you control GERD with PPI. That is more important, okay? That is important thing. Then if it is no dysplasia, you can repeat biopsy and endoscopy within 1 year. If it is continuing as a no dysplasia, then you can repeat every 3 to 5 years. Okay. If it is low grade dysplasia, you have to do a biopsy with Seattle protocol. If it is showing no dysplasia, in 3 to 6 months. You can repeat the biopsy. If it is showing no dysplasia, then annual surveillance for 2 years. If it is low grade dysplasia, then you can repeat every 3 to 5 years, like no dysplasia. You can follow the protocol for non dysplasia. If it is confirming low grade dysplasia again after 3 to 6 months, then you have to do endoscopic ablation. Okay, or surveillance every 6 to 12 months. If it has already progressed to high grade dysplasia, then you follow the algorithm of high grade dysplasia. So high grade dysplasia, what do you do? If it is there is no visible lesion or a visible lesion, you do an endoscopic resection for removal and staging. So the invasion into the submucosal space is called T1B. Very small lesion which is there in the mucosa only. When you are taking a biopsy, it is important that you take both the mucosa and submucosa. Then only you can identify the depth of invasion, because that determines the management. So if there is a visible lesion, you do an endoscopic resection. You stage the disease. If it's more than T1B, which means submucosal involvement, you go for esophagectomy with lymphadenectomy. If it's a very small thing, you can go for ablation, making sure that there are no residual metablastic disease. You can repeat every 8 weeks. Multiple sessions may need to be done to remove all of it. Then you can repeat biopsy every 3 months and then annually thereafter. If there are no visible lesion, you can do an endoscopic ablation, okay, every 8 weeks until eradication. Then the biopsy protocol, 3 months for 1 year, then 6 months for 1 year, then annually thereafter. Then we have considered the esophagectomy in high grade dysplasia. If it is more size, lymphovascular invasion, multifocality, patient is preferring surgery rather than repeated surveillance. Then unable to eradicate adenocarcinoma or progression of the disease, failed ablation technique, and stage esophageal function. These are some of the indications for surgery in high grade dysplasia. I've added a picture on Achalasia cardia due to building up of pressure and the failure of relaxation of esophageal sphincter. There is the dilatation of distal esophagus, which is in barium enema, it is called bird beak appearance. Manometry is a diagnostic investigation. For treatment, you can give either botulinum toxin to make the lower esophageal sphincter relax. You can attempt pneumatic dilatation, making sure that it will not perforate. And for very large dilated esophagus, you can't do a pneumatic dilatation. Helosmyotomy is the usual surgical procedure, or newer things like per-oral endoscopic myotomy, that is called OM. So that's a clear. Coming to hiatal hernia. Hiatal hernia means usually there is diaphragm, and in the line of diaphragm we have the gastroesophageal junction. But when there is a hiatal hernia, the gastroesophageal junction may get lifted up like in a sliding hernia, or the gastric content may herniate through that defect into the chest cavity, alongside the esophagus, which is called the paraesophageal hiatal hernia. Type 1 is sliding type. Type 2 is paraesophageal. Type 3 is both paraesophageal and sliding. Type 4 is when stomach, colon, small intestine or spleen all herniate to the chest. Okay, then I wanted to talk about Zenga diverticulum. Zenga diverticulum means there is a inferior constrictor of the pharynx which has two parts, which is called the cricopharyngeus and the thyropharyngeus. So this is the cricopharyngeus and we have the thyropharyngeus. In between that, the esophagus can get herniated through this defect here. okay, which is called Zenga diverticulum. Okay, now what happens is the food content can get accumulated here. Okay, that can lead to bad breath, which is called halitosis. There can be difficulty swallowing. There can be chronic cough. Okay, in barium swallow, you can get a picture of Zenga diverticulum. Treatment options can be myotomy of the cricopharyngeal muscle alone, which I told that that defect is causing the inferior constrictor of the pharynx has a defect that is causing the Zenga diverticulum. So you can cut open this muscle alone, or you can do a myotomy plus diverticulectomy. Diverticulectomy means removal of the diverticulum. Myotomy with diverticulopexy, you are repairing the diverticulum, or you can endoscopically by division of the septum between the diverticulum and the esophagus, that is diverticuloesophagostomy. That is Dolman's procedure, which can be done for Zenga diverticulum. Coming to esophageal corrosive injury, there can be it can be due to accidental or purposeful ingestion of caustic chemicals. It can be mainly by alkali or acid. Usually in India, we have with acid, or it can be due to alkali also. Alkali means pH is more than 7, acid means pH is less than 7. The important difference is alkali is causing more injury, deeper injury, and there is liquefactive necrosis. But acid is the injury caused by acid is limited due to the coagulum layer. So liquefactive necrosis, there is extensive necrosis with the alkali. Acid may lead to later on may lead to strictures and all. So usually the fate of this acid or alkali or corrosive injuries, it can then itself lead to perforation. Okay, at presentation itself may lead to perforation. That is one case, or it can lead to severe ulceration. Okay, and this ulceration can later on lead to fibrosis, then can lead to stricture. Okay, or in rare cases can lead to carcinoma also. So this is the fate. So when a person comes with a doubtful, case of ingestion of any caustic chemical of a corrosive injury, never do a gastric lavage. It's contraindicated because again the content will come in contact with the esophagus, and it will lead to more damage than before. So never do a gastric lavage. You have to do stabilization of the patient. Sometimes the patient may be in severe respiratory distress and tracheostomy may be needed. Endoscopy is done for prognostication, usually with minimal usage of air to dilate to prevent perforation. Late complication like stricture can be treated by dilatation, but in acute cases, if they are having a stricture formation, you never do dilatation in the fear of perforation. But late, when they come with stricture, you can do dilatation, not like a single sitting. You can do multiple attempts uh, to treat the stricture. This is the endoscopic classification of caustic chemicals. There is edema and hyperemia in the grade 1. Grade 2A means only localized ulceration and blisters. Grade 2B means circumferential and deep ulceration. Coming to 3 means deep ulceration along with scattered areas of necrosis. 3B means extensive necrosis, and grade 4 means perforation. That is caustic injury. Added a slide on foreign body in esophagus and trachea. So usually this is one of the classical thing that people, especially young kids, ingest the coin and they come. So when you see a chest X-ray, how do you identify if it is in the windpipe or the food pipe? Usually it's said that in the PA view, If it is you know like a round shape, coin shape itself, it's usually in the esophagus. If it is in the if it in the lateral X-ray we are seeing the coin shape, it is in the trachea. Okay, and these are the common sites of obstruction for esophagus due to their normal anatomical constructions at different sites. One at the cricopharyngeus muscle, which is the most common site of obstruction, around 75%. Then where the esophagus crosses the front of aortic arch. Then at the level of main bronchus. Then at esophageal hiatus as it passes through the diaphragm. Then I wanted to highlight the difference between Mallory Weiss and Borha. So Mallory Weiss is seen in severe chronic alcoholic or due to repeated vomiting and retching that can lead to mucosal tear in the esophagus. Okay, it is incomplete tear in the mucosa and submucosa, which can present with hematemesis, and there can be sometimes pain. When you do an endoscopy, you can see that there is mucosal tear. It is usually self-limiting. But what about Borha? Borha means there is perforation of the esophagus. So the content has leaked into the mediastinum. So there is pneumomediastinum, and there is one sign, classic sign called Hammond sign, which is crunching sound upon auscultation of heart due to pneumomediastinum. There can be severe pain, chest pain, and shock. The patient can be in shock. There can be subcutaneous emphysema. Uh, it is the complete rupture at the lower thoracic esophagus. So this is again the difference. Mallory Weiss is the mucosal tear in alcoholic or repeated vomiting. Borhavis esophageal transmural tear or perforation, and esophageal air and fluid leak into the nearby areas, which is pleura and the mediastinum. Mallory Weiss can present with vomiting, retching, hematemesis, and epigastric pain. Borhav, there can be chest pain, vomiting, retching, upper abdominal pain, odynophagia, fever, dyspnea or septic shock if they have already gone into sepsis. And subcutaneous emphysema can be seen. Also, we have told about the Hammond sign, which is crunching sound upon auscultation of heart due to pneumomediastinum. Endoscopy can be diagnostic for Mallory Weiss. For Borhav, you do not attempt endoscopy because the content is already leaked into the mediastinum. You can't do a barium also, which will again leak to the mediastinum and cause more trouble. So you never do a barium study in Borhav. So if there is suspicion, you can do a CT or contrast esophagography with gastrographin. Chest X-ray can show evidence of pneumomediastinum and pleural effusion. Pleural fluid analysis can show exudative, very low pH and very high amylase. Treatment, Mallory Weiss usually resolves spontaneously. Borhav, you have to do a surgery for thoracic perforation. Now, a word on dysphagia. How do you work up dysphagia in a patient? So, dysphagia can be due to the problems in the oropharynx or due to the esophageal. Uh, Oropharyngeal, it is difficulty initiating swallowing, so there can be choking, coughing, and nasal regurgitation. So it can be neurological like cortical, bulbar, or peripheral problem. Like in a post-stroke patient, if there is bulbar involvement, there can be difficulty in swallowing. Or there can be muscular problem like muscular dystrophy, polymyositis, myasthenia gravis, or cricopharyngeal muscle weakness. Or if there is a structural problem like Zenger diverticulum, thyromegaly, cervical spur, etc. Esophageal problem, it can be differentiated based on the nature of dysphagia. If it is only to solid food or both solid and liquid. If it's both solid and liquid, it can be a neuromuscular disorder. And if it is intermittent, it's called diffuse esophageal spasm. If it is progressive, it's called achalasia. And reflex symptoms predominate in scleroderma. So scleroderma can also present with dysphagia, and that is due to reflex symptoms. Now, dysphagia to solid food only may be due to mechanical obstruction like lower esophageal ring, or progressive cases like peptic stricture or carcinoma, especially in a patient who is more than 50 and there is history of weight loss. Now coming to peptic ulcer disease. So peptic ulcer disease, one of the important etiology is H. pylori. H. pylori is most commonly associated with duodenal ulcer, also associated with gastric ulcer. So peptic ulcer are two types, duodenal ulcer, gastric ulcer. Both are associated with H. pylori, but H. pylori most commonly predisposes to duodenal ulcer. NSAID abuse can also lead to peptic ulcer. Duodenal ulcer, the epigastric pain is relieved by food. This is mostly given in the literature, but may not be, evident in every patient. Gastric ulcer, epigastric pain is aggravated by food. Duodenal ulcer usually present with melena or lower GI bleed, and gastric ulcer usually present with hematemesis or an upper GI bleed. Both are upper GI bleed. Melena means through the lower tract. That's what I meant. Melena means thick, tarry, black stool due to digested blood, which is passing with the stool. Hematemesis is blood mixed with food or vomitus. Investigation is endoscopy. It is specific as well as sensitive. For detecting H. pylori, because for peptic ulcer disease, you have to do an H. pylori eradication with the regimens. So you have to understand if they are positive for H. pylori or not. For that, you can do a biopsy specimen for urease test and culture. You can do an IgG antibody against H. pylori. You can do a stool antigen or urea breath test. Urea breath test is what is routinely done in the surveillance test and all. So treatment, antacids like aluminum hydroxide and magnesium trisilicate. H2 antagonist like cimetidine and famotidine. PPI like pantoprazole, omeprazole. Now this differs because duodenal ulcer is mainly due to H. pylori. So you do an H. pylori eradication. That is your main target. Gastric ulcer is used to mainly due to the break in the mucosal barrier from of the stomach. See, every time stomach is having an acidic pH, but if it has to become sensitive to the acid, that means the mucosal barrier is broken down. That is why it is getting predisposed and it is forming ulcers. So that is why you are protecting the stomach from the acid by giving antacid, or you can reduce the production by giving like H2 antagonist or proton pump inhibitor like pantop and omeprazole, or mucosal protective agents like sucralfate, misoprostol, and bismuth salicylate. H. pylori eradication is mostly, we are not saying that we do not give it in gastric ulcer, but it predisposes mainly to duodenal ulcer. So you give a triple therapy. That is for 7 to 14 days, you can give omeprazole, clarithromycin, and metronidazole. Okay. Or clarithromycin, you can also give tetracycline, I think. So you can remember it like OMC. OMC, that is the triple therapy. After the 7 to 14 days, after stopping of the drug, 2 weeks later, you can do a urea breath test again. If there is complete eradication, you may not repeat the regimen. Otherwise, you will have to go for a repeat therapy with maybe a quadruple therapy. This quadruple therapy is, you can remember like OBMT, that is omeprazole, bismuth subsalicylate, metronidazole, tetracycline for 14 days. Okay, again after 14 days, you do a urea breath test, confirm that H. pylori eradication has been done. There is also a sequential regimen, which is omeprazole and amoxicillin for 5 days, followed by omeprazole, clarithromycin, and tinidazole for 5 days. Mainly, we are following triple and quadruple therapy. Now, gastric ulcer that does not respond to medical therapy requires surgical intervention. An appropriate operation for antral ulcer is anerectomy with a gastroduodenal anastomosis, which is Billroth 1. And vagotomy is not nearly as effective in preventing recurrence in gastric ulcers. It is important to realize that the management of gastric and duodenal ulcers is not identical because etiologies are different. Duodenal ulcers are associated with acid hypersecretion, while gastric ulcers are associated with impaired mucosal defense mechanism. Both are associated with H. pylori. Duodenal ulcer mostly associated with H. pylori. Gastric ulcer, 75% are associated with H. pylori. A gastric ulcer is much more likely to harbor a malignancy as compared to duodenal ulcer. Gastric ulcer should always be biopsied. If a gastric ulcer fails to heal after appropriate medical management, it should be excised. So the management and the etiology for gastric and duodenal ulcer is different. Both are associated with H. pylori, but mainly duodenal ulcer is associated with H. pylori. So for both, you have to focus on H. pylori eradication. Gastric ulcer, the mucosal membrane is damaged. Duodenal ulcer, uh, duodenal ulcer is associated with acid hypersecretion. Gastric ulcer, it is due to the defect in the mucosal barrier, so that the acid is now becoming more problematic to the gastric mucosa. It has always been exposed to acid. The gastric content has always been acidic in nature, but somehow the stomach wall has now become um, sensitive because of the breakdown of the mucosal barrier. So in gastric ulcer, you focus on the protection of the mucosal surface by, maybe you can symptomatically you can improve by giving antacid and reducing the production of acid, but that will not take away the problem from there. But for duodenal ulcer, if you're reducing the secretion of the acid by vagotomy, you can uh, control the symptoms. And gastric ulcer is more predisposing to malignancy than a duodenal ulcer, so it should always be biopsied. These are the types of gastric ulcer: type 1 in the lesser curve, type 2 combined gastric and duodenal, type 3 is in the prepyloric, type 4 is juxtaesophageal, type 5 is drug related anywhere in the stomach. Why we are classifying this? Because the treatment can differ. Okay, when you are having a ulcer here, or when you are having an ulcer here, the treatment may vary, and the uh, surgical management may vary. Okay, now this is the Forest classification of bleeding peptic ulcer. uh, in stage 1, there is active hemorrhage, so there is spurting arterial hemorrhage or active oozing hemorrhage. Stage 2 is evidence of recent hemorrhage, like a non-bleeding ulcer with a visible vessel. So there has been a recent bleeding, or ulcer with an adherent clot, or a flat ulcer with a dark base. Now, stage 3 means clean based ulcer, that is no active hemorrhage. So low risk means 2C and 3, that is a flat ulcer with a dark base or a flat ulcer with no active hemorrhage. They can be managed as outpatient with proton pump inhibitor. High risk is 1 to 2B. They require inpatient care. You just have to know if there is evidence of active bleeding or recent hemorrhage, you have to admit the patient. If there is a flat ulcer with dark base which is covered with hematin, or no active hemorrhage, you can outpatient, and you can do maybe a scheduled endoscopy. Now, upper GI bleeding, there is two score. One is Rockall score and another one is Glasgow-Blatchford score. Now, Glasgow-Blatchford score is to identify if the patient has to be managed outpatient or they need endoscopic treatment. So that is mainly by elevated BUN, which means blood urea nitrogen, which means they are severely dehydrated, there has been severe bleeding. Low HP, low BP, elevated heart rate, which again indicates dehydration, melena, they all accounts for only 1 point. Mainly it is urea, okay, and low hemoglobin. Syncope, liver disease, heart failure also can increase the risk. Rockall score is the mortality predicting score, which is like this, like age for it is 0 to 3 points for age, for shock, comorbidity, mainly cardiovascular or renal or liver failure. Then, if it is malarious, it is very low mortality. GI cancer can have a high mortality. Bleeding stigmata, if there is visible vessel and active bleeding, there can be high mortality. Now, if a patient has come with GI bleeding, what do? You have to assess the hemodynamic stability, resuscitate the patient first. You can give IV octreotide. It can cause splanchnic vasoconstriction, mainly in case of variceal bleeding and all, and it decreases portal circulation and pressure. Then endoscopic therapy with a variceal ligation or sclerotherapy. Then long-term treatment to decrease the risk of recurrent bleed. You can give nadolol. Okay, so this octreotide also you can give, and you can give terlipressin also. It also causes this splanchnic vasoconstriction, that is called terlipressin. Then prophylactically, to prevent further bleeding, you can give beta blocker like nadolol. You can do repeat endovascular ligation sclerotherapy. Nitrates can also reduce the bleeding, and you can follow up the patient. If there is persistent or recurrent bleeding, you can go for TIPS. TIPS means transjugular intrahepatic portosystemic shunt. So this is a slide on mainly variceal bleeding. Okay, variceal bleeding for upper GI bleeding. You can do TIPS. That is transjugular. It is from the term itself, transjugular. So through the jugular you are going, intrahepatic, inside the liver, portosystemic shunt. So mainly the liver blood supply is coming to the liver by the portal system. So you are doing a portosystemic shunt. The portal vein is being shunted to the systemic vein, so that the variceal bleed can be um, uh, managed. One of the commonest complication of this TIPS procedure is encephalopathy. Okay, encephalopathy. Post-TIPS encephalopathy is one of the commonest complications. You can go for a balloon tamponade or a liver transplant in severe cases. Okay, now coming to diverticulosis, which can be a common cause in elderly for lower GI bleeding. So most common site is sigmoid colon. So what happens in diverticulosis is there are outpouchings from the colon. So here in the barium study, you can see there are several outpouchings, multiple outpouchings here. So that is called diverticulosis. If it is getting inflamed, it's called diverticulitis. Okay. So diverticulosis, the risk factors are low fiber diet. There has been a question which asked what is the most common risk factor for diverticulosis. It's a low fiber diet because it predisposes to motility abnormalities and higher intraluminal pressure. Inactivity and obesity, muscle wall weakness from aging and illness like Ehlers-Danlos and Marfan. High intraluminal pressures causing outpouching to occur at a point of greatest weakness, most commonly where vasa recta penetrate the circular muscle layer, therefore increased risk of hemorrhage. So diverticulosis means several outpouchings. Diverticulitis means there is inflammation also. Usual site is sigmoid colon. There is a staging called Hinge staging for treatment of diverticulitis. If there are small diverticulitis, when there is inflammation, how do you treat? If there is small pericolic abscess, you can go for medical management with antibiotics. If there is a large abscess or fistula, you can go for medical as abscess drainage with or without resection with primary anastomosis. If there is purulent peritonitis or a ruptured abscess, you have to go for a Hartmann procedure. If there is a feculent peritonitis, again Hartmann procedure. I'll just show you what is Hartmann procedure in a while. So coming about GI bleeding, there can be upper GI bleeding or lower GI bleeding as discussed. Upper GI bleeding is above the ligament of Treats, lower GI bleeding is below the ligament of Treats. So that is the landmark, okay, of upper GI and lower GI. So see, it is attached somewhere the second part of duodenum, okay. So the upper GI bleeding can be due to peptic ulcer disease, erosive esophagitis, esophageal varices, arteriovenous malformation, Mallory-Weiss syndrome, cancers of the upper GI. It can be visible or occult. That is, no visible evidence can be there, which can be detected by the fecal occult blood test or signs of iron deficiency anemia. In elderly, if there is iron deficiency anemia, you have to always evaluate for malignancy. Then lower GI bleeding below the ligament of Treats. In elderly, main cause is diverticulosis and can be hemorrhoids, colorectal cancer, AV malformation, intestinal ischemia. So intestinal ischemia, there is something called mesenteric ischemia, there is something called ischemic colitis. Those two are different entities. See, mesenteric ischemia is like a very acute event. So there is an embolus, maybe a cardioembolic patient with AF. There is an embolus which dislodges to the mesenteric vessel. There can be acute abdominal pain. On CT, there can be evidence of ischemia. So that is mesenteric ischemia. Ischemic colitis means it's a like a chronic process due to reduced blood supply. Okay, so as I mentioned, this is a word on Hartmann's procedure. So what is Hartmann procedure? So suppose there is an area of diverticulitis and there is inflammation, okay, and there is an active perforation or it's very severe. So you can't do right away, you can't do a resection and anastomosis. So instead what you do is you do a colostomy. So the diseased area is resected and there is closure of distal rectal stump. This stump is closed and then you do a colostomy. And then after you can do a revision with anastomosis in approximately 3 months. That is an Hartmann procedure. First you do a resection with the distal stump being closed and you do a colostomy. In 3 months you can come and revise the procedure and do a anastomosis. Now I'll show the difference between mesenteric ischemia and ischemic colitis. So mesenteric ischemia is very acute. There is severe abdominal pain which is out of proportion to the physical findings. There can be vomiting and bloody diarrhea, blotting and minimal peritoneal signs early in the course. Then the patient can go in for hypertension, shock and sepsis. Usually in a patient with history of AF, there is an embolic event. Or in chronic case like postprandial pain from mesenteric angina. That is called mesenteric angina. Fear of eating and weight loss. Common site is superior mesenteric artery supplied territory, which is the midgut. They usually ask the watershed areas. Usually in options, what is the usual site of mesenteric ischemia? It is splenic flexure, most common site. Or other watershed areas like left colon and sigmoid colon. What are watershed areas? That means, suppose we have the transverse colon, uh, ascending colon, transverse colon, and descending colon. So we told this is the splenic flexure. Why this is a watershed area? Because the SMA is supplying this ascending and transverse colon, which is superior mesenteric artery. Inferior mesenteric artery is supplying this uh, descending colon. So this area is supplied by a branch of this as well as this, right? So the blood supply can easily be compromised in this state, in this area. That is called a watershed area, usually the splenic flexure. It can also be left colon or sigmoid colon, another watershed area. Then a lab investigation, a leukocytosis, which can be a non-specific sign. There can be lactic acidosis, which is late finding due to shock. Amylase lactate CKLP can be used to observe the progress. Hypercoagulability workup if suspect venous thrombosis. Usually it can be an embolic event due to history of AF. Chest X-ray can show portal venous gas, intestinal pneumatosis, or free air if there is perforation. Contrast CT show thickened bowel wall, luminal dilatation, SMA or SMB thrombosis, mesenteric or portal venous gas, and pneumatosis. CT angiography is the gold standard for acute arterial ischemia. So what is the difference between ischemic colitis and mesenteric ischemia? Those are two different entities, often mixed together, but they are different entities. Mesenteric ischemia usually affects the small bowel. The usual the artery indicated is the superior mesenteric artery. It's usually occlusive due to thromboembolic event. In a patient with history of AF, it can be sudden onset and the pain is out of proportion. Treatment is urgent surgery. Ischemic colitis usually affects the large bowel, usually non-occlusive due to low flow states. It's more gradual in onset, moderate abdominal pain and tenderness with bloody diarrhea. Usually conservative management, surgery is occasionally considered. You can give also intra-arterial papaverine. Papaverine, they say for non-occlusive ischemic event. Papaverine, okay. That's all. Thank you. Also, in a patient with abdominal artery aneurysm, if they underwent a surgery, few days later they can come with abdominal pain. There is bloody diarrhea, so that can also indicate ischemic colitis because there can be a prolonged event of ischemia during the surgery and all. So that can also indicate ischemic colitis. So we'll talk about the rest of the things in the next session. Thank you so much.